Good morning, my friends. This is a recorded presentation that I held recently for SRATS Congress 2021. For those who could not attend to this session and they could be interested in ultrasound guided procedures today. This is my point of view as a radiologist, and you will see what can we do with ultrasound in the following slides. Good morning, everybody. Thank you all for being here. My talk today will be about ultrasound guided procedure, and it is my radiologist point of view. So I will um, explain my point of view as a radiologist, and in the end we'll have more time for discussion and questions if there are any. So why ultrasound guided procedures? Because you can guide injection in almost any joint without using X-ray in a very fast and non-painful manner. The purpose of this work is to present the actual status of this procedure with example from our experience. So I will start my point of view. Um, what can we do using ultrasound guidance? These days you can have in your consultation room this small device, and you can have it coupled with a phone or with a small tablet, and you can do very fast ultrasound. Where does ultrasound fit in MSK imaging? What can ultrasound bring that MRI, CT, or X-ray can't? So, to answer these questions, ultrasound can be done very fast, can be done bilaterally for comparison, and can be performed dynamically. You can actually see structures during movement, especially in the shoulder. Ultrasound can be a therapeutical method, not just an imaging one, because you can do these ultrasound guided procedures. Ultrasound is not expensive. Ultrasound is harmless, does not use ionizing radiation. Where ultrasound is not so helpful. You must understand that ultrasound cannot penetrate the bone, so we can only see soft tissues that are in front of the bone, and you cannot see inside the bone. Ultrasound cannot depict deep structures of the joint like cruciate ligaments, menisci, or retropatellar cartilage. Ultrasound also cannot properly identify labrum cartilage lesion of large joints. Also, ultrasound can very well depict fractures. It is not the gold standard for that. CT or MRI is better. Also, ultrasound machines are readily available almost everywhere. I just showed you some very portable device. Ultrasound expertise in MSK is not so readily available. You need training to understand and to interpret and to report uh, ultrasound, um, MSK ultrasound. And another downside is that ultrasound is operator dependent. What this means is the expertise has a long curve, and learning is done by doing, not by reading about doing. So there is about experience. Why ultrasound is so good for some joints and not so good for others? Well, shoulder is very well imaged with ultrasound because its mobility. Um, but for example, depiction of a bunker lesion, it is difficult and the correct characterization is impossible. Uh, Ultrasound is not so good for the knee because ultrasound is, can miss some important structures like menisci or cruciate ligaments, and is not the first choice in a trauma of the knee, but it is ideal for synovium in rheumatological disease. You can very well appreciate the activity of a rheumatological disease in any joint with ultrasound. At the next level, what kind of ultrasound guided procedure can be done? After proper training, of course, you see here there is a course that I have attended in the last 5 years yearly in Belgium, University of Antwerp, where we perform ultrasound guided injections into uh, fresh cadavers, um, which are very, very similar with the live tissues of the human patients. So I advised, don't try this at home, don't try this at from the first day to a patient, because you need training. Um, so we can inject in almost every structure of the musculoskeletal system. We can inject peritendinous, perineural, intraarticular, intrabursal, intramuscular. We can evacuate fluid, abscesses, hematomas, collections. We can perform dry needling of the tendons. We can barbotage or aspiration of calcification inside the tendons. Uh, but the question is, what is the level of evidence for this procedure? And this is a very, very long talk. We do not have time for this. But there are some European guidelines which just appeared. There are from 2019 to 2020. Um, and there are only 3 chapters right now, but there is work in progress for the others. So part 1 regards the shoulder, part 2 elbow and wrist, and part 3 nerves of the upper limb. And it was a panel of experts selected from 45 radiologists from 11 countries in Europe, with good experience and research in interventional musculoskeletal procedure, and they all work together in order to uh, do some guidelines. So this work is now readily available on European radiology, and it is graded by level of evidence. So you can I will refer to these guidelines along this lecture. How we do this practically, these ultrasound guided techniques? There are 3 ways of injecting something with ultrasound guided technique. The in-plane technique, where your needle is parallel with the probe, and you see the needle all along. You see the tip of the needle here inside the vessel, and you are sure that the needle is not penetrating the posterior wall of the vessel, because you can see the shaft and also the needle, the tip of the needle. There is also the out of plane technique, in which the needle is perpendicular to the probe, which means you will only see you will not see the whole length of the needle, just the section of the needle. And if the section is in the proper position, like here, you can see the needle in cross section inside the vessel, but you need to move the probe up and down to be sure that the needle tip is not already here, but and the plane is not right, because you are not positioning correctly the probe. It's quite demanding to use this technique, but sometimes it is preferable to use this instead of in plane. And there is the other kind of technique, which is marking the place with an ultrasound, with the ultrasound, making a cross on the skin, and then do the injection the old-fashioned way. Uh, I will start with guided procedure for the shoulder, and I will make references to those clinical guidelines that I already spoken about. So we can inject into the glenohumeral joint, and the level of evidence is one that ultrasound guided glenohumeral joint is more accurate than palpation guided injection. We can inject into the bursa, and the level of evidence is also one that is it is better to inject with ultrasound guidance than on palpation technique. Weekend barbotage or irrigation for calcific tendinopathy of the shoulder, and the level of evidence is one, that ultrasound guided percutaneous irrigation of calcific tendinopathy is feasible, is safe and effective uh, in calcific treatment tendinopathy with one needle or two needles. The peritendinous injection for long head of the bicep tendon, uh, we can do that with the help of ultrasound. We can inject steroid along the tendon. The level of evidence is 2. We can do dry needling of the supraspinatus tendon or PRP injection, um, and the level of evidence is 2 and 3. Um, for reducing pain, but it is inferior to PRP injection. So dry needling is good, but it is inferior to PRP in 6 weeks. So, and we also can do cyst evacuation. This is an example of injection into the subacromial subdeltoid bursa, steroid injection. You can see the phases. You enter with the needle. You first aspirate, then you inject the solution into the bursa, and you see it distending. This is a large supraspinatus calcification. You see it is huge. Uh, when you do the dynamic maneuvers to detect impingement, you see that there is a mechanical obstacle. The tendon cannot pass under the acromial arch because of this calcification. So there is actually no use of injecting something into the joint because it's a mechanical obstacle and needs to be removed surgically. This is another calcification inside the tendon, and I will show you the maneuver of barbotage. This is the calcification. This is the needle. You see, first I puncture the needle. You see there is a not very solid nodule, but nevertheless there is calcium, a lot of calcium. After I puncture the nodule, you see I perform this injection aspiration technique for many times, and you see this under ultrasound how it works. You actually empty the calcification from its content, and in the end it looks like this, like an empty shell. You use a lot of syringes because you need to extract this um, calcium milk, which has this deposit of calcium inside. And in this particular case, I used 4 syringes, and you do this until you get almost clear fluid from the shoulder. So the level of evidence for this procedure is one, that it is safe and effective procedure, and improvement it's about 50% of 1 year follow-up, just 1% 10% complication which are minor. And also there is another statement with the level of evidence one, that this barbotage reduces risk of adverse events when compared with extracorporeal shockwave therapy or subacromial injection alone. What can we do more? We can inject into the glenohumeral joint via posterior approach with a level of evidence of 1. It is better to use ultrasound than do it by palpation. You can see the labrum, you can see glenoid here, you can see articular joint, articular capsule. This is infraspinatus muscle. You use this type of positioning and you can avoid very well the labrum by injecting using ultrasound guidance. Let's skip to the elbow. What the evidence we have here for intra-articular joint injection? The level of evidence is 2, that is better to inject it via ultrasound. For PRP of the lateral epicondylitis, the level of evidence is 2, that injection with PRP under ultrasound guided injection is better than other minimally invasive procedure. And dry needling or fenestration or percutaneous needle tenotomy can be beneficial and as a standalone treatment, but with the level of evidence just 3. Steroid injections are effective for pain relief in lateral epicondylitis. However, they should be avoided as a first line of treatment for chronic disease, and the level of evidence being 2. Tendon injection for bicep tendon, medial epicondylitis, and triceps tendon are insufficiently studied yet, are not sufficiently studied yet, and could be the same level of efficiency as for lateral epicondylitis, but the level of evidence nowadays is just 5, and we can of course evacuate bursitis. How about dry needling? For lateral epicondylitis, it is very easy and quite effective, I would say, but the level of evidence is 3. You need to puncture multiple times the tendon. You see here the tendon. This is a radial head. This is a calcification. If you can fragment this calcification with the needle in order to get it smaller and easier to be absorbed. You can perform medial dry needling, medial epicondylitis dry needling. Like in this case, you see this is the medial epicondyle, this is the medial flexor tendon, and you perform this in the same way as lateral epicondylitis, but the level of evidence is 5. You can do dry needling and PRP injection. You see this is the first step. We first perform dry needling, create multiple channel into the tendon, and then inject the PRP solution, which seems to be with level of evidence 2, but with no evidence of superiority compared with other minimally invasive procedure. So you can inject this, you can do dry needling or other invasive procedures, but the level of evidence is 2, that they are good, and we haven't decided yet which is better. We can do dry needling of lateral epicondylitis with calcification. As I already told you, you can try and fragment this calcification under ultrasound guidance. Now let's skip to the wrist. We can inject the tunnel carpal perineural, and the statement is that it is safe and it is efficient to treat the carpal tunnel syndrome, and the level of evidence is 1. Intra-articular joint injection with the level of evidence 2. The ultrasound guidance is very good compared with palpation guidance. Injection for the first extensor compartment, the tenosynovitis, is safe and effective with level of evidence 2. For trigger finger, the level of evidence is 3, that it has a better result than physiotherapy, and but open surgery, this seems to be superior with level of evidence 2. And another statement which has a level of evidence of 2 is that ultrasound guided injection for inflammatory arthritis are significantly less painful than palpation method. And ganglion cyst evacuation has a slightly higher recurrence rate compared to surgery, and the level of evidence is 4. So what can we do here? We can have this trigger finger steroid injection. You see here there is fluid around the tendon underneath the pulley system, and we inject with ultrasound guided technique some steroid under the pulley, and the patient went very well in a couple of weeks. We can also inject the Kerven tenosynovitis. You see here tendon, you see tenosynovitis here, inflammation around it, and this is the needle injecting the fluid, the steroid around in a first compartment of extensor. This is another the Kerven tenosynovitis. This is MRI images. You can very well see the tendon from the first compartment, which are quite thickened, signal change, and peritendinitis. This is the ultrasound, which is quite similar with what you see on MRI, and the injection is performed in this way, and you inject in the first compartment with good results. This is the median nerve that we need to inject for carpal tunnel syndrome. The preferred way to do it is from the medial, from the ulnar side. We have always in mind that this is the Guyon canal, and we avoid it because of the ulnar nerve, and we inject perineural with guidance, and we can do it under the nerve, or superficial, or in both ways. So this is Guyon canal here. For the hip, we can do intra-articular joint injection. We can inject peritrochanteric bursa. We can inject around the nerve, or for piriformis syndromes. We do not have yet some European guidelines. So if you see this peritrochanteric bursitis, you can inject it very easily with ultrasound in this way. These images are from a book of my mentor, Professor Jan Gillen from Antwerp, Belgium, and he explains all these procedures. This is example of a hip injection. You see very well that the aim is to inject somewhere around the femoral neck into this capsular recess. In particular, in this patient particularly, you can see the labrum here. You can see the acetabulum here. This is the femoral head, and I injected this almost into the joint because there are some deformities along the femoral neck. So it was easier to do it like this. This is another injection where I try to avoid this huge osteophyte, and I injected lower into the femoral neck, but nevertheless it was successful because you see the joint capsule here inserting on this spot, and the needle is here just into this recess, which of course communicates with the joint. For piriformis syndrome, you can see here there is inflammation around the sciatic nerve, and you have here the MRI image and ultrasound image to better understand the the anatomy, you have gluteus maximus, you have piriformis, and then sciatic nerve. Um, with this approach from here to here, you can protect the sciatic nerve from directly injecting into it, like in this case. This is the sciatic nerve, this is piriformis, and this is gluteus maximus, and you see the injection done into the piriformis muscle. Um, you can inject the sciatic nerves at the level of quadratus femoris. Here the nerve is more superficial. It is only gluteus maximus on top of it, and the quadratus femoris is profoundly to the nerve. You can see here the nerve on the sagittal view, and you can see dynamically gluteus maximus, quadratus femoris, and very well seen this sciatic nerve with a double fascicle here. And you can inject very near to the nerve, um, very close to the nerve. For knee procedure, you can do intra-articular injection, but this is very easy to be done without ultrasound guidance. You can evacuate fluid, you can aspirate cyst, and you can treat iliotibial band syndrome. This is an example of a parameniscal cyst aspiration. You can aspirate this. This is the needle. After you aspirate, you can inject some cortisone inside. Of course, it does not treat the cause because the cause is ruptured meniscus, but you can relieve the acute pain that the patient had. You can treat iliotibial band syndrome by injecting into the painful side. You see here that the iliotibial band is thickened. This is the femoral condyle. You see here the iliotibial band and the Gerdy tubercle, and the injection done like this at the insertion, and the fluid which flows around the iliotibial band. For the ankle, you can do intra-articular injection, peritendon injection, Achilles tendinopathy, retrocalcanean bursitis. For Achilles tendinopathy, you see this is a huge tendinopathy which covers half of the tendon, the superficial half of the tendon, and we did this PRP injection into the tendinopathic side. You see the fluid going very well inside the tendon, and it was very easy to inject. When you inject a tendinopathic tendon, it's very easy to inject. The normal tendon is very difficult to inject. You see this image how it's actually done. This is another case of Achilles tendinopathy pre and post stem cell treatment. This is how it looked like at first at the presentation, that huge tendinopathy with huge neovascularity inside the tendon, which covers all the thickness of the tendon and also the uh, profound Kager fat. And after 8 months of after stem cell treatment and a lot of physio and kinetotherapy, this is how this looks. It's still tendinopathic, but it does not have new neovascularity inside. This is an injection of retrocalcanean bursitis with an out-of-plane technique. This is why you don't see the needle track. You just see a point here, which is the needle injecting the fluid into this small bursa. This is how you see the tibiotalar joint injection. This is tibia, this is talus, and this is the anterior capsule. Here there is very small amount of fluid, there is no capsular thickening, and you can inject directly into the joint very easily, like this, for arthro MRI, for example. You can also treat all sort of peritendinitis. This is peroneus tendon injection. You see the needle, you see the tendon and fluid around it. For foot, you can do any sort of intra-articular injection, or you can inject the Martin mortal neuroma. This was the first metacarpophalangeal synovitis in a football player. You see the synovitis here, fluid, synovium thickening, and injection with cortisone into the dorsal recess. This is why ultrasound is very good for mortal neuroma detection, because you can do dynamic maneuver to provoke the mortons to pop out on plantar side. You see, when you squeeze the fingers or the metacarpal heads together, the morton pops up. And of course you can do injection, which is usually done by the dorsal aspect. It's less painful to do from the dorsal aspect. So in conclusion, regarding interventional US guided procedures, they are safe. If you use proper aseptic protocols, it is fast, but it requires good training and good machines. They are more efficient, but they need the proper indication and execution, and they are less painful depending on the experience. And I should know this, that radiologist does not usually choose the agent to be injecting. The orthopedist or the rheumatologist do. We as a radiologist, we diagnose I don't know, inflammation or bursitis, and the orthopedist chooses the agent to be injected, or if there is a need for this injection.